Good afternoon, everyone. Hello, everyone. I am Dr. Vickie Lynn, and I'm here to answer any questions you might have about HIV and stigma. I want to thank CME Outfitters and the AIDS Institute for hosting and organizing this event. I'm grateful to have the opportunity to discuss HIV and stigma with all of you. Thank you for coming and spending the next half hour with me. While we wait on others to join, I'm going to further introduce myself. I'm a public health and social work professional, and I currently work as a faculty member at a university. My research focuses on integrated care and how we can combine biomedical and behavioral health interventions to address prevention, care, and treatment specifically for people living with HIV. We've done a great job at addressing the biomedical aspects of HIV, but have not done such a terrific job at holistically addressing the health and wellness of people living with HIV. And we've definitely not done a great job about addressing stigma. And although I have a wealth of academic knowledge, I also have personal experience as I am a person living with HIV, or should I say, HIV is living with me. I contracted HIV in 1985. I was still a teenager at the time, and then diagnosed in 1991 with an AIDS diagnosis. So it's been an incredible journey for me. So I have firsthand experience of the impact HIV stigma has on a person. I can't speak for all people living with HIV, but I can provide a little insight into how HIV stigma impacts people's health and wellness and what we can do to reduce or eliminate stigma. But before we get started, I want to first acknowledge that today is World AIDS Day, and World AIDS Day is when people worldwide unite to show support for people living with HIV and to commemorate those who have died from HIV and AIDS-related complications. I feel truly blessed to still be here talking with all of you. We've come a long way since the beginning of the HIV pandemic, but we still have a long way to go. Each year in the United States, 30,000 people are newly diagnosed with HIV, and we lose 7,000 people each year to HIV and AIDS complications. Worldwide, those numbers are even larger. We know without a doubt that people living with HIV today who are in care and treatment and who achieve and maintain an undetectable viral load have absolutely no risk of sexually transmitting HIV to their sexual partners. And people living with HIV can live a normal lifespan, but stigma remains a huge barrier to accessing care and treatment. So here we are 40 years later, and we're still talking about the impact stigma has on prevention, care, and treatment. It's hard sometimes to imagine that HIV has now been around for 40 years, and it's hard for me to imagine that I have lived my entire adult life with HIV and an AIDS diagnosis. And as I stated a few minutes ago, we've come a long way, but we still have a long way to go. So I am here to answer any questions that you might have in relation to stigma, and I will do my best to answer most of the questions that you have. And so you can put your questions into the chat box. So one of the first questions is, how do you define stigma as it applies to HIV and AIDS? So although there are varying definitions of stigma, and I'm going to provide first an overall definition of what stigma is. And in the 60s, Goffman, he was one of the first to actually define stigma. And he defined it as an attribute that links a person to an undesirable stereotype, leading other people to reduce the bearer from a whole person to a tainted, discounted one. So stigma links an attribute or characteristic about a person to a stereotype. So you can think about these attributes as labels, and we'll talk more about that as we move forward. So in the case of HIV stigma has been linked to a variety of stereotypes and myths, and HIV is also associated with other highly stigmatized conditions like substance use, homelessness, and mental health. It's also linked to behaviors and populations, and I think importantly, it's linked to sex. And we still, as a society, have difficulties talking about sex. So HIV stigma is an irrational or negative attitude or judgment towards people living with HIV or HIV in general. And we know that HIV stigma is similar across the globe, meaning other populations, other cultures have HIV related stigma very similar to what's here in the United States. We also know that HIV stigma has a profound impact and negative consequence on public health efforts towards prevention, care, and treatment. And individuals living with HIV face multiple levels of stigma from family, friends, from society, even structural stigma at the macro level that has to do with criminalization of HIV and then other policies related to HIV. So HIV stigma is associated with any character. Let me rephrase that. HIV stigma or stigma associated with the characteristics often comes from a lack of understanding or from fear. And we've seen this over the past 40 years. We have a great deal of inaccurate and misleading information in our society. And in the early days of the HIV pandemic, the media and other news outlets fueled that stereotype, myths, and negative narratives. Our foundational understanding of HIV is that it was a gay disease and people living with HIV were seen as monsters or not full people. There's widespread bias and discrimination based on HIV. That's been widely documented. I'm just looking at the chat box. Another question has come in. How has stigma impacted you and your HIV treatment? So for me personally, I think that HIV over the past 40 years has definitely negatively impacted who I am as a person and how I've received care. As a long-term survivor, someone who's been living with HIV for 36 years, stigma has had a profound impact on who I am as a person. In the beginning of the epidemic, I was disowned by my family and friends. Many people simply just stopped calling, similar to what other survivors have experienced. My mom was no longer willing to hug me. She was afraid every time I walked into the house. Anything I touched would be wiped down or simply thrown away. And the pain and fear that I saw in other people greatly impacted how I perceived myself and how I navigated the world around me. So I ended up internalizing that stigma and began using substances to hide from my pain and discomfort. I didn't know how to cope. I didn't know any way of dealing with my diagnosis. I think it was an entire year before I actually met another woman living with HIV. All I knew was what I saw on television, which was just fear-based. And in the early days, simply trying to find a medical provider who was willing to see me was almost impossible. I had a great job, great health insurance, and I tried to find a medical provider willing to see me, and I got thrown out of many doctors' offices. We don't see people like you. We don't know what to do with people like you. Get out of our office. So it took me almost a year to actually even find a medical doctor willing to see me. So my experience with stigma over the years has changed. In the beginning, it was very difficult. I took that stigma and I internalized it. I ended up losing my job, my home. I was at one time sleeping under an overpass in the downtown area of my town, just waiting to die. I had lost almost all my T cells. I was down to 80 pounds. I started seeing things, hallucinating. I was actually even locked up in a mental institution and diagnosed as a paranoid schizophrenic. It turned out it was age-related dementia, but at the time, because there was still so much stigma in relation to HIV, nobody believed anything I said. They just treated me not as a real human. And that was a very difficult time for me. And it was only through the help of others in the community, people who eventually offered me housing, that that was about in the mid 90s that I got what I call a second chance at life. The new medications came out. I started taking those. I had housing, so I had a safe place to put my head at night. And I was able to regain my health through the medication I was taking. So over the years, I've been able to manage my health and wellness, but I still face stigma every time I walk into a doctor's office, every time I walk into a dentist's office. And I think that some of that is profound in how I feel about myself. I've been able to overcome some of that, knowing that the stigma that people project onto me is not really about me. It's about their lack of knowledge or understanding about HIV, how it's transmitted. I see we have another question coming in. How do you think stigma impacts people living with HIV or older people living with HIV differently? That's a really great question. I think that people diagnosed today experience stigma in a very different way than what was experienced in the early days of the pandemic. We've seen the messaging around HIV starting to change, especially I think over the past decade. We're seeing more people thriving with HIV, and that message is getting out into the communities. We still have a long way to go because there's still a lot of stigmatized messages that are out there. But for those of us who experienced long-term living with HIV for a long term, I don't know if you've heard the phrase 1,000 cuts. So every time we experiencing stigma doesn't happen like in one instance. It's over and over and over again. So those of us living with HIV long term have repeatedly experienced that stigma. And it's like 1,000 cuts, getting a small cut every time we experience that. And today we know, as I said, that people living with HIV can live a normal lifespan. We have no risk of transmitting the virus as long as we're maintain an undetectable viral load. So that has helped to really shift how we see HIV. I think the COVID pandemic has also brought in new education to the masses, so to speak, on what a virus is and how it's transmitted. With COVID, it's airborne. With HIV, it's a different route of transmission. So I think that we can use the COVID epidemic as a way to educate the public more so on a virus, what it is, how it's transmitted. And HIV is simply a virus. That's all it is. It's because it's transmitted sexually, it carries this stigma, and we need to move past that by talking about it and just having frank, open conversations about it. We've seen some pretty horrific public health campaigns globally. I believe it was in 2004 when the French put together a campaign that depicted people living with HIV as spiders and scorpions. So it was posters that showed someone having sex with a spider or someone having sex with a scorpion, which activists shut down pretty quickly. But the intent was to scare people into getting tested and protecting themselves while having sex, but it depicted people living with HIV as monsters. Also in 2009, there was a campaign in Germany that depicted people living with HIV as Hitler or Stalin. So again, it was a scare tactic to get people to protect themselves and use condoms and not engage in sexual acts or unprotected sexual acts. However, it again depicted people living with HIV as monsters. So activists were pretty quick at shutting down those campaigns and explaining to the people that designed them why those were not helpful messages. So it's those kind of messages we saw in the early days of the pandemic and sometimes still see today. And it's not only those early illustrations and messages, it's also the terminology and the language we use to talk about HIV and AIDS. The words we choose create a story, a narrative, and they help to fuel stereotypes sometimes. There's a particular phrase that we should never use when referring to a person, and that's the term infected. So, over the years, I've done several workshops on language, stigma, and HIV, and worked closely with Valerie Wojciechowicz. And in our PowerPoint presentations, when we talked about the term infected, she liked to show a picture of an open infected wound, a sore. And that's the image most of us have when we hear that term infected. So to be called HIV infected woman, HIV infected man over and over and over again starts to wear on your spirit. It also fuels those stereotypes and myths about other people. So we see it in the research literature, we see it in public health campaigns, and because researchers continue to use it, then I think that that gets disseminated into the general population, and we often repeat. Even though I've done workshops for years on HIV stigma and language, I still sometimes use stigmatizing language because it just slips out of my mouth because we continue to read it. I can't even tell you. I did actually did a Google Scholar search yesterday on the phrase full blown AIDS, and it's still being published in research literature today. Although full blown AIDS does not have a medical diagnosis, there's no half blown AIDS. We are still seeing it being published in research literature today. And there is no medical definition for that. So the fact that researchers are still using it, journal editors are still allowing it to be published, and then even we as providers are sometimes, I've seen providers still use that phrase. This helps to fuel that misinformation and that stigma in society. um, I do want to mention, because my work in relation to stigma and language first started when I was doing some work on myself, in relation to recovery and from substance use. I began to pay more attention to the words and phrases I used in my own mind to describe myself, and that was so very uncomfortable. And during that time, I was also working on my master's in public health and reading research articles. I'm reading this terminology in the research publications, and I'm like, they're talking about me, and it's so uncomfortable to be referred to as an infected over and over again, or an AIDS patient, or an HIV patient. And so through my research, I went back looking to find out where the people first language came from. And the first written understanding of people first language came from the Denver Principles. Now, there are some talk that people first language came from the mental health community at some conferences prior to the Denver Principles. But the Denver Principles, written in 1983, were the first to publicly write something about people first language. And we are not AIDS patients. We are people living with AIDS diagnosis. We are people living with an HIV diagnosis. And we need to shift that language from referring to people as their diagnosis to first referring to them as people. So HIV stigma, we always ask, or we know how HIV is transmitted. Well, we also need to know how HIV stigma is transmitted. And that's transmitted through the terminology, the pictures, the messaging that we portray and put out there about HIV. So I call it HIV stigma communication. So HIV stigma communication is the language or terminology that perpetuates myths and stereotypes, that uses labels to describe people, and uses demeaning and outdated phrases. And even here we are 40 years later, and we're still talking about how stigma impacts prevention, care, and treatment. And it's exhausting and it's unnecessary. And I hope that we can continue to move past this. I know I'm rambling. Does any other questions that people have? Let me see. What can I do to help address stigma and bias as someone not living with HIV. I think that some of the things that we can do for people not living with HIV is to be respectful first in the language that we use when we talk about HIV, is to be very careful on that terminology. And unfortunately, HIV stigma, it's not just HIV stigma. There's stigma in relation to racism and gender identity and sexual orientation and poverty and other aspects or characteristics of people's lives. So it's this combined stigma. So we just, whether we're talking about HIV, whether we're talking about substance use or criminal behavior or anything, we need to be careful on the words that we choose. So in order for people living with HIV or those who might be at risk for HIV, we want to use terminology that makes them feel safe to access services. We want to treat everyone with respect. I think it's quite interesting, since I'm now Dr. Vickie Lynn and I'm also Vickie Lynn living with HIV, is when I present myself as Dr. Vickie Lynn, I'm treated so very differently than when I'm present myself as Vickie living with HIV. It's just profound. I just had an instance happen with a medical provider that had included some documentation in my patient chart that was not accurate. And I tried to no avail to get someone in their office to delete that information out of my medical record. But it wasn't until I mentioned that I was Dr. Vickie Lynn that I got any movement at all. And whether I'm Dr. Vickie Lynn or Vickie living with HIV, I'm still the same person and I deserve the same respect. So everyone living with HIV deserves the same respect. They don't deserve anything less. I am no better than anyone else in society, and I don't deserve that extra respect just because I have doctor in front of my name. I deserve that respect because I'm a person, and all people deserve the same respect. We have another question about healthcare providers in particular to reduce stigma, bias, and barriers to care. I think that it's the same, it's very similar, that providers should also be using respectful terminology when they're talking to I don't even like to use the word patient, because we're actually people. We're people most of the time. It stems from that language and the terminology we use. It's to be more respectful and to listen to the people that we're working with, whether it be in the doctor's office, the behavioral health office, wherever it is that we're working with people. We simply need to treat them with respect. We also need to advocate for changes at the macro level. There's policies and laws on the books that criminalize people living with HIV. So those need to be changed. They're not being kept, they're not in line with the science that we know today. So I think there's 39, oh no, I can't remember how many. I think there's 39 countries that still have very severe my mind just slipped. There's 39 countries that still have travel bans on people living with HIV. So if I wanted to travel to another country, there are certain countries that still would not allow me to move there or live there or work there. I think I got off track a little bit, that we were talking about providers and how they can help. And I think that just being mindful that everyone is a person, and that, I would like to see community health centers being open to everyone in the community and not just for people living with HIV. We have fragmented that system of care. It's always been fragmented, but we have HIV care services over here and then other services over here. So we know that if you're going to that facility serves people living with HIV. So just walking in the door is stigmatizing. I think some of the organizations around the nation are still naming themselves like an AIDS network kind of thing. And we need to move away from naming community health centers that. If we can stay in general, we want to teach, we want to teach, we want to treat everyone at risk for or living with HIV in the same way. And separating that is not helpful. I think reducing stigma in relation to HIV, mental health, substance abuse can do a lot to reduce stigma. Um, what else? I think that clinics also could benefit from having hard conversations about stigma. So it's that implicit bias within us that we aren't aware of. We need to sit down in the break room with everyone who works in a clinic environment to talk about how might we be stigmatizing the population we're serving? Are we telling jokes in the office? Are using outdated terminology or terminology that's still stigmatizing to people? I think clinics and organizations themselves, even though they've been serving people living with HIV for decades, might need to have these hard conversations and discussions with the entire staff of, because I even know that people who are working in these clinics are fearful of revealing their status because of the stigma that even exists within those systems. So it's having those hard conversations, maybe measuring the implicit bias within an organization to understand what can we do differently, how can we present ourselves differently, how can we work with our clients differently to reduce that stigma. From Twitter, what things have you found helpful when faced with stigma in my own life? In my own life, and I know we only have about 5 minutes. In my own life, I used a lot of substances in the first 15, 20 years of my diagnosis. Unfortunately, I believed the doctors when they told me I was dying. So I kind of lived my life as if I was dying and hid my pain and fear in a lot of substances. It took a lot of work on myself, and it took a lot of work from people who believed in me, people in the community that offered me housing, that helped me stabilize my life. And then I had to pay attention to the things that I was saying to myself in my own head. And then understanding that people's stigma towards me isn't about me. It says more about them. That's really easy for me to say, but there are still times. I mean, I recently went into a dental office and the hygienist refused to clean my teeth. This is something that people living with HIV face. When we go outside of the HIV care system, we're still faced by stigma in healthcare settings. And I think educating others, talking about it, having things like what we're doing today. I may be a Dr. Vickie Lynn, but I'm also Vickie Lynn living with HIV who's experienced a great deal of stigma, and I've overcome some of that. And it's providing other people hope that even though you might be living with this condition, that does not define who you are as a person. It doesn't define how far you can go in life. It doesn't define anything about you. It's simply a virus and nothing more than that. And I hope that I can help inspire other people to follow their goals and dreams. It was a long road to get where I am. And it took a lot of work on myself. But I think that we have seen a lot of changes in the community in the past 10 years, in the past few decades even, and I hope that we continue to see changes where more people are talking about HIV, more people are using respectful language, and we're taking a look at the implicit bias that we might have, not only towards HIV, but towards poverty and racism and other inequities and inequalities in our society, because those all fuel HIV and stigma. We have about 2 more minutes. Let me think. Any other questions you guys have? I can leave you with this last quote. I think it's quite powerful because I believe the language and the terminology we use is incredibly powerful. So Dr. Kelly, who has done work in the substance abuse and recovery area, he said that health conditions are not a choice, but our language and terminology and how we as a society describe it is. So changing our language is incredibly powerful for reducing the stigma and limiting those stereotypes and discrimination. All right, we have about 1 minute. I can't believe it went by so fast. And I thank each of you for coming here and spending this past half hour with me. And again, thanks to CME Outfitters and AIDS Institute for putting this together. And I hope you all have a wonderful day and mind your words.